I'd like to welcome you all here to our first webinar. TDSA is delighted to be sponsoring the webinar in conjunction with the Respiratory Dental Institute. We're joined tonight by Associate Professor Michael Stubbs and Dr. Linda Schachter. Hello, Linda. Hello, Michael.
Hi, Peter.
Tonight, I thought we would just have a chat about sleep apnea and how the dentist can become involved in, I guess, diagnosis and treatment. Linda, if I could hand over to you first and foremost, I wondered if you could just give us a bit of number one, give us a little bit of an idea of your background, but number two, perhaps talk us through sleep apnea and how it affects the population. Fairly broad question, but what sort of symptoms the dentist might look for, diagnosis and treatment options. That's a big subject to be covered in a short time. If I could hand over to you.
Thank you, Peter. So going back on my background, I'm a respiratory and sleep physician and have been so for 23 years. I got involved in sleep actually really early in the piece when I was offered to do an extra year of training and then would be a sleep specialist in addition to being a respiratory physician. When I started doing sleep medicine, I actually loved it. And the reason for which is that you actually, when you treat someone and you treat their sleep apnea or you treat their sleep disorder, you actually change their life. People go from being tired and sleepy to feeling waking refreshed and having lots of energy throughout the day. So it's actually can be quite life-changing for people. So that's how I got into sleep medicine, and now the majority of my practice is actually based in sleep medicine. I do now 90% of my work is sleep related and 10% is respiratory. So going through how do people present and how the dentist can be involved. First of all, sleep is a really common condition, and as we get older or as we get fatter, we're more likely to get sleep apnea. So the current thought process is that at least 10% of the adult population have a problem with sleep disordered breathing. And some recent studies out of Adelaide have actually showed that in men over the age of 40, 50% of them actually do have a problem with sleep disordered breathing. So this is a very common condition. It gets worse as we get older and it gets worse as we get fatter. And basically our population is getting older and it's getting fatter. So they're the problems. People present with symptoms, so they can present with different things. So they can present with sleep problems, so that might be snoring. Somebody may have seen them stop breathing, such as witnessed apneas. They may wake choking at night. They may wake with nocturia, or even just have disturbed sleep. When they wake in the morning, they wake unrefreshed or feeling like they're still tired. They may wake with a dry mouth or with a headache. So and then the other thing that they may have is daytime symptoms. So where they're tired and sleepy during the day. They may not think as clearly. They may describe grogginess, may describe poor attention, poor memory, and poor concentration. So there's actually can be a multitude of symptoms. Patients may not actually even describe any symptoms because they might be quite good at justifying their daytime symptoms, and they may actually be justifying their daytime symptoms because we've got busy lives, we're not sleeping as much as we should. They're young kids. So people may not actually even describe any of these symptoms. Where the dentist has a unique opportunity is that they're actually seeing people annually. And so they can actually look at their upper airway. They can see that the person's got a narrow upper airway. They may see big tonsils. They may actually see changes of bruxism that actually may be a little bit of a hint that the person has a problem. And then when the person is in the chair and you can see that their upper airway is narrowed, and then maybe an opportunity to actually ask the patient about snoring, witnessed apneas, or choking episodes overnight. The other opportunity is in the waiting room. So we've got a range of questionnaires that actually are predictors of sleep apnea or predictors of sleepiness. And these questionnaires may actually start the conversation with your patient about whether they've got sleep apnea or whether they're just too sleepy. So there's several things that the dentist can be involved with that realistically that the doctor may not actually get that opportunity. It's also from a treatment perspective. So once actually, even from a diagnosis perspective. So once it's suspected that you've discussed it with the patient, you may actually do one of the screening questionnaires, and then there's the opportunity to do either a screening test or an actual sleep study. And that may actually be discussed with the dentist and the patient what you'd like to do. And the screening tests, sleep studies go between level 1 and level 2 sleep studies, which are full sleep studies either in hospital or at home. And then level 3 and 4, which are screening tests. And they're just looking at sleep apnea. And really, they're positive predictive value. So if the person has a problem, they've got the problem, they've got sleep apnea. But if it's negative, then further investigations may be warranted. And then the dentist also has an opportunity for treatment. So, depending on the severity of the sleep apnea, treatments may range from nasal CPAP or continuous positive airway pressure to a mandibular advancement splint to things like positional devices, weight loss. So, there's a whole range of treatment options that are available, and the dentist can be involved with the treatment, such as in a mandibular advancement splint, or for directing the patient where to go and how to get treatment.
Lynn,
And then
sorry,
following up as well. Sorry about that, Peter. Yep.
sorry, Linda. And then the following up. Yeah,
Yeah,
absolutely.
involved in following up. And every patient that has sleep apnea should be followed up, whether they're not compliant with treatment, whether their symptoms are ongoing. Everybody does need follow up. Even if they do get a mandibular advancement splint, it is important that there's follow up to make sure that the sleep apnea is fully treated, that the snoring's fully treated, and that the patient is actually using whatever treatment that they actually decide to go with.
Fantastic. Linda, thank you for that overview. Michael, Associate Professor Michael Stubbs, if I could hand over to you, Michael. So you've received a referral for a mandibular advancement splint from a sleep physician. Could you talk us through the process there? What's next?
Well, first of all, I suppose I should say my background is in oral medicine. So I've been an oral med specialist for about 19 years. And the reason I got into the area of sleep is because I specialise obviously in TMD and in particular chronic facial pain and mucosal disease. And one of the things I really found amazingly rewarding is that most of the sleep patients we meet are very straightforward. You do have a huge positive impact on their life, and it's actually personally very rewarding to see somebody transformed from being weary, irritable, perhaps difficulty concentrating, and suddenly they come in, they say, "You've changed my life," and it's great. And as a dentist, and Linda's right, we actually look at the upper airway. And I think if I had a referral from a patient, from a sleep physician to see a patient, first thing we would do is that the patient has been properly assessed. That's so critical. There are so many potential patients that come in or might say, "Oh, look, I don't care about the apnea, I just want the snoring fixed." It's not good enough. You need to make sure you're treating the complete picture. And that's why you'll find, as part of our program, is that we actually teach you how to actually interpret sleep studies, understand the different levels and the significance of having them done. What I would be keen to know is, firstly, you need to explain to the patient what a dental device looks like and how it works. We understand it pulls the mandible forward. We understand it pulls the tongue forward and therefore opens up the posterior airway. It's important that you assess the patient to make sure they don't have an underlying TMD. So it's very simple, part of our normal routine. We palpate the joints, the muscles. I always ask some pretty standard questions, such as, do they find when they chew their food, does their jaw get tired or sore? Do they wake in the morning with a stiff or tight jaw? The rationale is very simple screening tools. Very quickly you can determine if there's any symptoms of TMD. the relevance is, Pete, when you pull the mandible forward, as you know, the tongue, but also it strains the joint. So if there is a sore jaw to begin with, it's just a matter of understanding that and then appreciate that you're not going to start your patient at maybe the typically 50% forward. You might start them a lot less. And in our course, we actually talk about the criteria of selecting patients and how you can actually manage them and what pathways you should follow. Once the patient's agreed to the device, we make them. There's a number of great range devices that exist. Obviously, the TDSA has several that are terrific. And then, you know, the important part as a dentist is it's not just fitting the device, but you need to do the follow-up. You also need to make sure you communicate with the sleep colleague. If a sleep physician is good enough to send you the patient, you need to be good enough to actually write back and say, thanks for the referral. So the sleep physician then knows that patient is being managed and they're not disappeared into the ether. And as we know, you know, if the patient hasn't been managed as in treated, as they get older, they tend to get worse. And so at least having some opportunity to at least address their current issues and then sending them back to the sleep physician in many cases to have another study done to see how effective the treatment is, how effective the device is. The sleep physician usually gives you a good indication at the referral whether that's what they'd like. Sleep physicians have different expectations. Some sleep physicians, if the patient's only got mild apnea, they're quite happy to say if the patient's feeling more refreshed and there's no snoring, they're quite satisfied with that. Anyone who's moderate to severe apnea, they would have a study done automatically to make sure you're getting validation of how effective it is. And again, it's working with the sleep physician. So that's where, you know, when you get into this area, you need to appreciate you're part of a team and you're not just the only person managing the patient. And with the relationships you build with your sleep physicians, like Linda and I, we've worked together for years, it's fantastic. And, you know, you can really help the patient and, you know, the sleep colleague will help you and support you as far as if you have any problems with outcomes and vice versa, you can help the sleep colleague. So that's how I would look at it and that's how I'd go about it.
Michael, thank you for that. That sounds like a great summary. Linda, thank you also. This is really, I guess, our first webinar, so it's very much an introduction, and I hope that's given everyone a flavour for what is involved, a little bit of a taste for what can be done. I'd encourage you to visit both our website, so TDSA, the Dental Solution, and the Respiratory Dental Institute website. Please visit, have a look. You can screen through the RDI website and just have a look at the course content.
Peter, if I could just say, Linda and I created this, didn't we, Linda? Because we've taught for other groups and things for many years, we understand that one of the biggest problems is you go to a didactic series of lectures, and at the end of that day, you walk away with a lot of notes, and then the excitement starts to pan out a bit because it's like, well, what do I do next? How do I get to the next step? How do I actually integrate this into the business, into their own practice? And one of the things we know from our course is that we designed this so that when you do the introductory course, at the end of it, you are competent to start to treat a patient. The advanced course is designed so that you are competent to start to deal with some of those complications that may or may not occur. And we also teach you how to bring this concept into your practice. So we've created, haven't we, Linda, a great, we call it like a special college, a masterclass, where if you engage in the courses, you can join our masterclass series and you can submit cases. We do webinars directly anyway, discuss cases you can participate in. And if you have a particular patient case, you can submit it, discuss it with us, both Linda and myself, and we can give you the guidance, hand-holding, if you like, to really give you that confidence. Because this whole concept, RDI, is really about confidence and confidence in you treating the patients and being comfortable doing it.
Absolutely, Michael. Couldn't agree more. I think there are times we do these one-day courses, and unless you implement it straight away, often that information, that knowledge is forgotten, isn't it?
Also, the fact is, you know, until you get confident in managing these patients. They are a bit scary. You are making big differences to them. And as idealized as we are that we're going to make a big difference in their life, which you are going to do, it does take a while to get used to doing it and making those changes. So we're happy to help you through the difficulties and through the first few patients till you get that confidence going. And even then, there is still patients that are going to be complicated and you will need a little bit of help. And that's what we're there for, because not every patient is simple, and often the first couple are the ones that actually are the difficult ones, and we want you to actually keep helping your patients.
Fantastic,
Yeah,
Linda.
actually, yeah, absolutely right. And also we submit, sorry, Peter.
No, you're right, Michael.
This is the introductory. We actually submit papers and things for discussion as well. So, you know, colleagues that are watching this that are really interested, you'll not only have the confidence to proceed with treatment, but also we'll attempt to make sure we keep you updated with, you know, any major breakthroughs as far as significant papers, benchmark papers. You know, the education part will continue on and on.
Yeah. That's great. And Michael, we are planning that series of webinars, and included in that, every second webinar we'll do some case studies, as well as having other specialists come and talk about their involvement, including surgery, those sort of specialties. I'm sorry, I probably was winding up a little bit too early before. Thank you both very much for your time again tonight. We very much appreciate the fact that you both had very busy days. We look forward to seeing you again, and thank you and good night.
Good evening.
Thanks, Peter. Thanks, everyone. Bye.
Bye.